In this video, you will learn about the structure and function of the adrenal glands. We will discuss the effects of epinephrine, norepinephrine, aldosterone, and cortisol. Then we will apply this knowledge to two important clinical conditions, Cushing syndrome and Addison's disease. The adrenal glands are paired, pyramid-shaped organs located on top of each kidney. Structurally and functionally, they are two glands in one, the adrenal medulla and the adrenal cortex. This organization allows the adrenal gland to coordinate both rapid and long-term responses to stress. Let's begin with the adrenal medulla. The medulla is the deep central region of the gland. It contains nervous tissue and functions as part of the sympathetic nervous system. You can think of it as a modified sympathetic ganglion. When the sympathetic nervous system is activated, preganglionic neurons stimulate chromaffin cells in the medulla. These cells release the hydrophilic catecholamine hormones, epinephrine and norepinephrine. Because they are water-soluble, they cannot cross the plasma membrane. Instead, they bind to G-protein-coupled adrenergic receptors on the surface of target cells. These receptors activate second messengers to regulate enzyme activation, producing relatively rapid responses. Their effects depend on the tissue and receptor subtype present. In the liver, beta-adrenergic receptors stimulate glycogenolysis. In cardiac muscle, beta-adrenergic receptors increase heart rate and the force of contraction. In the small airways of the lungs called bronchioles, beta-adrenergic receptors cause smooth muscle relaxation. This bronchodilation leads to improved airflow. In blood vessels supplying the skin, digestive organs, and urinary system, alpha-adrenergic receptors cause smooth muscle contraction, leading to vasoconstriction. This redistributes blood flow away from non-essential organs and towards skeletal muscle and vital organs. Now let's contrast these catecholamines produced by the adrenal medulla with the steroid hormones produced by the cortex. The adrenal cortex is the superficial region containing glandular epithelial tissue. The cortex is divided into three zones. The most superficial layer is the zona glomerulosa. This layer produces aldosterone. Aldosterone is a mineralocorticoid that acts on the kidneys. It increases sodium reabsorption and potassium secretion. Because water follows sodium, aldosterone increases blood volume and blood pressure. You will learn more details about aldosterone when we cover the physiology of the urinary system. The middle layer is the zona fasciculata. This layer produces cortisol. Cortisol is a glucocorticoid and plays a central role in the long-term stress response. The deepest layer of the cortex is the zona reticularis. This layer produces gonadocorticoids, primarily DHEA. DHEA is a precursor that can be converted to the sex hormones testosterone and estrogen. It may be helpful to break down the words mineralocorticoids, glucocorticoids, and gonadocorticoids to remember some details about these hormones. Aldosterone, a mineralocorticoid, regulates the blood levels of two important minerals, sodium and potassium. Cortisol, a glucocorticoid, stimulates gluconeogenesis to increase blood glucose level. And DHEA, a gonadocorticoid, can be converted to the gonadal sex hormones, testosterone and estrogen. These words all end with corticoid because they are steroids produced by the adrenal cortex. Because these steroid hormones are lipid-soluble, they diffuse directly across the plasma membrane. Now we will focus on cortisol as an example to study in more detail. Cortisol crosses the plasma membrane and binds to intracellular glucocorticoid receptors. The hormone receptor complex then enters the nucleus and alters gene transcription. This leads to the production of proteins that prepare the body for prolonged stress. A wide variety of target cells throughout the body respond to cortisol in different ways. For example, hepatocytes in the liver increase blood glucose by producing more pepCK, a key enzyme in gluconeogenesis. By stimulating gluconeogenesis, cortisol helps maintain blood glucose over hours to days. In cardiac muscle and vascular smooth muscle, cortisol increases blood pressure by stimulating production of adrenergic receptors. When these cells express more adrenergic receptors, their sensitivity to catecholamines increases. In the heart, enhanced responsiveness to epinephrine and norepinephrine increases heart rate and force of contraction. This produces greater stimulation of cardiac output. In blood vessels of the skin, digestive organs, and kidneys, increased catecholamine sensitivity leads to greater vasoconstriction. In hypothalamic neurons, cortisol stimulates production of proteins that promote hunger. Cortisol also suppresses the immune system by reducing inflammation. In leukocytes, cortisol leads to production of proteins that suppress inflammatory immune responses. Regulation by glucocorticoid receptors does not always increase transcription. For example, the glucocorticoid receptor decreases transcription of genes involved in inflammation. This dual regulation allows cortisol to both activate and suppress different pathways during prolonged stress. Glucocorticoid medications are synthetic derivatives of cortisol that are commonly prescribed to reduce inflammation and suppress overactive immune responses. Examples include prednisone and dexamethasone, which are used to treat conditions such as asthma, autoimmune disorders, allergic reactions, and certain inflammatory diseases. Cortisol production usually follows a 24-hour circadian rhythm, with highest levels produced in the morning and lowest levels produced at night. Chronic stress leads to a sustained increase in the production of cortisol. The release of cortisol is regulated by the hypothalamus and pituitary gland. CRH from the hypothalamus stimulates the release of ACTH from the anterior pituitary. Then ACTH stimulates the adrenal cortex to produce cortisol. This cascade is regulated through negative feedback. The hypothalamus will respond by increasing CRH secretion if cortisol levels in the blood are too low. Now let's connect this to clinical conditions. Cushing's syndrome results from excessive glucocorticoid signaling, most commonly due to long-term use of corticosteroid medications. Common symptoms include increased appetite and fatigue. Clinically observable signs include hyperglycemia, hypertension, and weight gain. Fat accumulation occurs along the central axis of the body, often concentrated in abdominal, dorsocervical, and facial regions. Meanwhile, the limbs become disproportionately thin and muscles atrophy. Hair loss often occurs on the scalp. In females, there may be increased hair growth on other regions of the body, including the face, a condition known as hirsutism. Skin becomes thin, bruises easily, and may form red or purple stretch marks known as striae. Wounds heal slowly, and the immune system is suppressed, leading to increased infection risk. Cushing's syndrome resulting from excess glucocorticoid medication will activate the negative feedback mechanism in the hypothalamus, leading to decreased production of CRH and ACTH. Adjusting the dosage or stopping the corticosteroid medication is the primary treatment for this condition. Cushing's syndrome can also result from tumors that increase cortisol production. Cushing's disease refers to the second most common form of Cushing's syndrome. This occurs when a tumor in the pituitary gland produces excess levels of ACTH, leading to increased production of cortisol from the adrenal cortex. Excess cortisol will inhibit CRH secretion through negative feedback in the hypothalamus, but the pituitary tumor continues to produce excess ACTH. In some circumstances, medications may be used to decrease cortisol synthesis or block glucocorticoid receptors. However, treatment for Cushing's disease often involves surgery and/or radiation therapy to remove the tumor. After the tumor is removed, these patients will often require medications to replace cortisol. Pituitary function may recover, but in some circumstances, pituitary function may be disrupted, requiring lifelong hormone replacement therapy. Occasionally, replacement for other hormones might be required, such as growth hormone, luteinizing hormone, follicle-stimulating hormone, or thyroid hormones. In contrast to Cushing's syndrome that results from excess glucocorticoid signaling, Addison's disease results from adrenal insufficiency, leading to decreased production of glucocorticoids and mineralocorticoids. It is most often caused by autoimmune destruction of the adrenal cortex. Patients may experience decreased appetite, fatigue, hypoglycemia, hypotension, weight loss, and abdominal pain. Hyperpigmentation of the skin, scars, and mucous membranes may also occur. Increased ACTH is responsible for hyperpigmentation in these patients because elevated ACTH can activate the receptor for melanocyte-stimulating hormone. Hyperpigmentation can also occur in patients with Cushing's disease that have a tumor producing elevated ACTH levels. Elevated ACTH occurs in Addison's disease because of the negative feedback mechanism in the hypothalamus and pituitary gland. Low glucocorticoid signaling will stimulate secretion of CRH and ACTH. However, the adrenal glands are not capable of producing cortisol in response to ACTH. Treatment for Addison's disease usually involves glucocorticoid medication as hormone replacement therapy. Understanding the structure and function of the adrenal glands helps explain why these disorders affect multiple systems. If we step back and look at the big picture, the adrenal gland coordinates stress in layers. The medulla releases catecholamines for immediate cardiovascular and metabolic effects. The cortex releases steroid hormones to sustain energy production and maintain blood pressure. The adrenal gland integrates rapid sympathetic signaling with slower endocrine regulation. This layered design allows the body to respond immediately to stress and maintain stability if stress persists.